A very warm welcome to all patients joining us today for this Patients Today event on the important topic of lung cancer. The treatment of lung cancer is a broad field in which diagnostics and therapy have developed rapidly in recent years. Every year, the ASCO takes place in Chicago, the largest and most important cancer congress for all indications, providing crucial impulses for clinical practice. Today, Professor Reinmuth, who attended the event in Chicago, will present the latest research findings on lung cancer to us in an easily understandable way. Professor Reinmuth is the chief physician at the Asklepios Lung Clinic, Gauting, Department of Thoracic Oncology, and heads one of the largest lung tumor centers in Germany, located in Munich. He also teaches at Ludwig Maximilian University in Munich and is the author of numerous publications on various topics. These cover different manifestations of lung cancer. My name is Heike Gantke. I am currently an ALK-positive lung cancer patient at stage 4 and a proud board member of zielGENau, which is a dedicated patient network for women with mutation-driven lung cancer. As with patients today, one of our most important goals is to inform patients about therapy options so that they can actively participate in decisions about their treatment. Because patients who are well informed about their condition tend to live longer, I am very pleased to now delve into selected studies with Professor Reinmuth that could significantly influence the future of everyday lung cancer treatment. We will begin with 4 studies on the topic of immunotherapy, starting with the Harmony-6 study, a phase 3 clinical research study for patients with advanced squamous cell carcinoma. After adenocarcinoma, this is the most common form of non-small cell lung cancer. Ivonescimab plus chemotherapy was compared to tislelizumab plus chemotherapy. Professor Reinmuth, the floor is yours.
Yes, Ms. Gantke, thank you very much, dear patients. I am actually truly and incredibly delighted to be here today and to have the wonderful opportunity to present this to you a little bit. I have been working in this specific field for more than 3 full decades now, and am very familiar with how it all started back then. Back then, it didn't feel like a beginning at all, but looking at it today, you really have to say that it was the primitive and dark stone age. Today, there is an incredible variety of innovative new ideas and groundbreaking concepts, new and also studies. We ourselves participate in a great many studies. I believe that in most of the studies that have led to approvals in recent years, we were also involved here in Gauting, including with ivonescimab. This is a medication that was presented in the Harmony study, which Ms. Gantke has already mentioned. There are studies in Germany, including at our site, but certainly also near you. This is a promising medication that has attracted a substantial amount of attention within the medical community over the past few years. It is truly remarkable and noteworthy that nowadays a vast array of scientific studies, medications, and innovative ideas are coming from China and are also being tested there. Here as well, ivonescimab is a medication that was originally researched and developed in China, and the results have so far only been extensively studied in patient populations within China. This concerns squamous cell carcinoma, a subtype of lung cancer. These are patients who are in stage 4, or essentially in stage 4, meaning that local therapy is no longer possible and only so-called systemic therapy can be administered. And these were patients who were receiving therapy for the first time. A group of eligible patients were carefully enrolled in this clinical study. There was either chemotherapy combined with an immune checkpoint inhibitor called tislelizumab, which is also a product developed in China, or chemotherapy with ivonescimab. And ivonescimab refers to a specialized type of so-called bispecific antibody. This is an antibody not with a single target like the checkpoint inhibitor, which targets either PD-1 or PD-L1, but with the bispecific one, there are 2 distinct targets, PD and VEGF. VEGF is a marker responsible for the formation of new blood vessels. And the combination is supposed to be less toxic than if you were to use 2 different antibodies, one against VEGF and one against the checkpoint inhibitor, and at the same time, it is also supposed to be more effective. This specific finding has never been demonstrated before in a large-scale clinical study. And this is the landmark study that is now showing it for the very first time. The primary endpoint was progression-free survival, which is defined as the time that patients should benefit from this first therapy for as long as possible. And then the second most important endpoint, the so-called key secondary endpoint, is overall survival. That is always the most important thing in any study, and up until now, this could never really be demonstrated with this combination. And with squamous cell carcinoma, it is important to note that these tumors often lead to significant bleeding, and when you alter the formation of new blood vessels, a potential adverse side effect can be that this bleeding increases them. And in some cases, it can even become dangerously severe. That is why in the initial early clinical studies where so-called anti-angiogenic drugs were developed, medical professionals and researchers became exceptionally cautious. And for this reason, there was even more intense focus and anticipation regarding these new data, particularly concerning the comprehensive safety profile. So not only the efficacy, but also the safety of this bispecific antibody against PD and VEGF was investigated here, and these are the data. The overall survival rate, as mentioned, the most important marker, was demonstrated a significant improvement both in patients with very low and with detectable levels of expression of PDL. This is a marker indicating how well a tumor responds to immunotherapy. And as you can clearly see here, the curves are virtually identical, which strongly suggests this additional inhibition of VEGF apparently also diminishes and levels out the significance of PDL to some extent. That means both groups of patients benefit. As you can observe from the data presented here, the curves progress a bit differently. If you look closely only at these distinctive pink-colored curves, you can see that the level up here is already significantly better. But the difference is still such that this specific therapeutic combination involving VEGF with this medication has been better in each case. And this also applied when you further divided the existing PDL1 expression between moderate levels or even very high levels of expression, which is the very best outcome, so to speak. Here too, the combination of ivonescimab with chemotherapy demonstrated superior efficacy compared to tislelizumab with chemotherapy, leading the researchers to conclude that overall, they reported a manageable safety profile consistent with previous studies and no new safety signals. That is something which is always gladly said, because it is usually the case. You have already conducted previously smaller studies, and overall, it really seems to work quite well. But you can still engage in a detailed discussion about it, because it has been observed that there are indeed patients in whom bleeding events were reported, and it has occurred in a significant number of cases. Now, how exactly do we define what qualifies as severe bleeding and what doesn't? That is something the treating physician has to decide. And depending on how much experience they have, it can be associated with more or less nervousness. Overall, with this combination, the side effects were mainly defined by the chemotherapy, not so much by this antibody. The question is, do I always need chemotherapy? Especially for patients with very high P expression, we often use only a monoimmunotherapy with a checkpoint inhibitor in Europe today. So no B-specific, no chemotherapy, nothing else. And the question we must ask is whether that approach might perhaps not be sufficient for these patients who are not receiving chemotherapy treatment, and are the data even directly transferable to our own specific circumstances? It's not that the data from China aren't credible, but rather that in some cases the patients are different. And there are also differences in smoking behavior in China compared to here. Nevertheless, I think it's fair to say that extremely exciting substance studies, as I briefly mentioned, are also being conducted here in Germany. And I do think that we can be genuinely hopeful that we might eventually get a significantly improved therapy for many patients, though possibly not for every single one of them. And the patient selection, which I have marked here with a question mark, is truly the responsibility of an experienced physician. How much bleeding is considered acceptable and how much is too much? So if someone coughs up a little blood, is that an exclusion criterion for this medication or not? What about tumors that have broken down? That too is a risk factor for more severe bleeding events during therapy. So we still have a lot to learn in this area as well.
Thank you very much. You have already described a bit of it. So that means these bleeding events occur in the area of the tumor when you say the patients are coughing up blood, or how should I imagine that?
Yes, usually it is, particularly with advanced tumors that have already broken down. Major blood vessels are frequently involved, and this situation can sometimes lead to much more severe and significant bleeding for the patient. You have to look very carefully at where the tumor is located. Are there large vessels involved? How exactly does that behave, perhaps during therapy? Since these tumors sometimes break down particularly well or remarkably fast under such anti-VEGF targeted therapy. Whether it is bispecific or not, whether it is actually better tolerated, I think we can't say that yet, because the data we currently have has mainly been collected from Caucasian patients and less so from Chinese patients.
Yes.
But it is undeniably exciting. And as for the potential adverse side effects, we will have to wait and see how they actually present themselves in clinical practice and in the context of regular everyday life, if this medication should also prove to be truly convincing and effective in Europe.
All right, so today we are going to be discussing individuals diagnosed with advanced stages of lung cancer. Do these bleeding events also play a role for the metastases? Or is it really only in the tumor environment in the original site?
So these medications can not only cause bleeding, but also thrombosis. And thrombosis is a clinical characteristic that generally increases the risk in a wide variety of tumors. So for that reason, the risk is a bit more than just being limited to the tumor. Nevertheless, these bleeding events are usually incidents that mostly originate from the tumor.
Okay.
That is why, up to now, we have not used substances of this kind in the first-line treatment of squamous cell carcinomas, simply because we were too afraid. But it should also be said that this was 15 years ago, when the first studies with these substances that target blood vessels were conducted at all. Perhaps people were a bit overly cautious in those earlier times. Today, we are much more experienced in the process of carefully determining which patient can tolerate what and how. There are also anti-VEGF receptor therapies that are approved for squamous cell carcinoma, but only in later lines of therapy. So, we have also gained a significant amount of knowledge in this area, as it certainly must be acknowledged today. So for that reason, I do believe that this medication can generally be used for patients with squamous cell carcinoma, just probably not for everyone. And how much better it is, and for which patients, with high or only with low PD-L1 expression, that's something we'll really have to see in the future.
That is certainly good to know. Okay, but in any case, it's already very promising that PD-L1 expression does not seem to play such an important
most
role
definitely
here, because there is always a fair amount of uncertainty regarding just how consistent those results truly are, especially concerning the expression of the tumor itself. I've also heard that depending on exactly where I take the tissue sample from, there can definitely be some significant variations in the pathological results. And it seems to be quite a bit more difficult to really have consistent reliability there, to make determinations.
Reliability is always difficult when you only get a very small biopsy sample, and even that can yield different results depending on which technique you use. But PD-L1 expression is also just an indicator or a probability marker. It is not an absolute marker. That means, for example, in Gauting, we have seen very good results in patients who have zero PD-L1 at all. And unfortunately, we also sometimes see patients with very high PD-L1 levels who show zero response to immunotherapy. So everything is possible. And accordingly, I believe that combinations are somewhat the direction in which many developments are currently heading, because the goal is to move patients away from chemotherapy more towards immunotherapy and further development of immunotherapies in order to make more progress there. Chemotherapy is not bad, but it usually does not achieve long-term success. This is different with immunotherapy, and hopefully it will also be different with bispecifics. And for that as well, the long-term observation from this study is currently still insufficient. One still cannot say in the long term whether the medication is better, because the observation period is not yet long enough for that. Currently, it is very, very promising.
Okay, nice. That is very encouraging news to hear for this specific type of lung cancer. In that case, I would suggest that we move on to the following research study. That's the OptiTrop Lung 05 Phase 3 study for advanced or metastatic non-small cell lung cancer without epidermal growth factor receptor or anaplastic lymphoma kinase mutations, but testing PD-L1 positive. And this is about first-line treatment. sacituzumab tirumotecan in combination with pembrolizumab compared to pembrolizumab monotherapy alone. It's your turn again.
Again, an exciting compound, and once again, this compound also comes from China. And as I mentioned earlier, chemotherapy is a treatment that does unfortunately cause quite a few different side effects, which of course are not nearly as severe as they used to be in the past, but are still, of course, very unpleasant for patients. Furthermore, this chemotherapy is also not really long-lasting in its effects. The tumor simply comes back again. So the question is, can we make this chemotherapy better? A realistic approach, which has been broadly pursued for several years now, is to create specific antibodies that target the tumor directly. These antibodies basically carry a potent chemo agent along with them. They bind to the tumor cell, smuggle this chemo agent inside, destroy the tumor cell, and also damage the neighboring cells. And that is essentially how it works. That is basically
I imagine it like a classic Trojan horse, right?
Trojan horse. Exactly. That's targeted chemotherapy, at least in theory. But it's not quite that simple. Is it really specific to the tumor cell, or does it break down beforehand somehow due to other processes? There are major differences. That's why you can't say that one is the same as the other. And these innovative and highly targeted antibody-drug conjugates, or in plain English, antibody-drug conjugates, here the specific medication is sacituzumab tirumotecan, also known as SAC-TMT. And this medication has now been rigorously evaluated in clinical trials against standard immunotherapy in patients with PD-L1 positive, which is not so rare, advanced stage lung carcinoma. Why? Because pembrolizumab as a checkpoint inhibitor is approved for PD-L1 positive NSCLC in America, not in Europe, where it is only approved for highly positive cases, but in America, and apparently also in China, it is approved for PD-L1 positive cases, and that's what was compared here. Sacituzumab tirumotecan plus pembro versus pembro alone. You immediately start to wonder, well, what if this had been compared to chemotherapy with pembrolizumab? Would it have been better then as well? We don't know. Here, only this so-called chemo substitute with pembro was compared to pembro alone. And we know that chemo with pembrolizumab is already better than pembrolizumab alone in patients with moderate PDL expression, not with high PDL expression, because in those cases, pembrolizumab alone is usually sufficient. So it's definitely an interesting study. Patients had to be in good general condition. Metastatic or advanced non-small cell lung cancer, just like we saw before. And this time it's all NSCLCs. A total of 413 patients were enrolled in the clinical trial. And last year at ESMO, the European Cancer Congress, which is the second very large international cancer congress alongside ASCO. And since ASCO wasn't quite as well attended this year, at least not in person, some even believe that ESMO could possibly become even bigger than ASCO. So last year at ESMO, it was clearly demonstrated that the progression-free survival in this study was significantly more favorable for pembrolizumab plus SAC-TMT. And now here is the overall survival. This is also the first study that has reached phase 3 in this specific therapeutic area. These are the data that have now been comprehensively updated once more. SAC-TMT with pembrolizumab has significantly improved progression-free survival. Hazard ratio 0.35, that's significant. You can see this huge difference between these two curves. Of course, where would the curve for pembrolizumab with chemo have been? Would it have been in between? Probably yes. It probably wouldn't have achieved the same results. But that's pure speculation because you're just imagining the curve. We didn't actually have that curve. And this is the overall survival. In this specific instance as well, you can clearly see that the overall curves diverge. Not quite as much as we saw before, of course, because a lot shifts again with the introduction of subsequent therapies, but the results are still clearly improved with the combination of SAC-TMT and pembrolizumab versus using pembrolizumab alone. Naturally, since I am comparing a chemo-like substance in combination with pembrolizumab against the drug alone, there are inevitably more side effects to consider. So especially bone marrow toxicity, which we all know from chemotherapy, also occurs with these antibody-drug conjugates. Unfortunately, they also cause hair loss, and they lead to additional side effects such as inflammation of the oral mucosa, and sometimes the surface of the eyes becomes dry. And especially the final two symptoms mentioned, namely The painful inflammation of the oral mucosa and eye involvement are often only seldom considered to be severe, but they can still really bother the patient and significantly diminish their overall daily quality of life. And that also depends on the chosen target of the antibody, meaning where this target is, where the antibody binds. Of course, care is taken to ensure that it is as specific as possible for the tumor cells, but it is never entirely and perfectly specific to the tumor cells, because we know that tumor cells were once normal cells and then underwent various biological changes. So it is assumed that all the characteristics these tumor cells have may sometimes also be found in other healthy tissues in the body. And that's why there are also some side effects. Fortunately, it was rarely discontinued. That was sometimes the consequence in less than 4% of cases. Therefore, it is fair to say that the medication is highly effective. When we look at the profile of side effects, it even works significantly better than what we have observed from other substances. But here too, the question is, what does it look like in Caucasian patients? The overall survival rate here too is not yet, well, it has shown some improvement, but it's still not really exceptional, simply because the follow-up period is not yet considered sufficient. And here as well, does every patient have to receive this, or is it enough to give it only to patients with moderate P? We know that the combination of chemo with pembrolizumab is better than pembrolizumab alone. However, we currently do not have access to this specific data simply because there were no dedicated therapy arms included in this study. So we also definitely need new and further studies here. Here too, these studies are being conducted in Germany, and accordingly, this is already something of a significant harbinger. The Chinese, with these bispecific antibodies and these antibody drug conjugates, these are all medications that are coming that will very likely increasingly make their way into the clinic, and many are being developed in the Far East. We can be very curious to see where all these medications will eventually find their place, especially in first-line therapy. And if so, what should I do then? Should I then use an antibody drug conjugate with bispecific antibodies? So there are many new ideas about what and how things can be combined. It's definitely going to be exciting.
Yes, it does sound exciting, actually. You have previously mentioned the Caucasian patients again. We are well aware of this fact from the targeted or mutation-driven patients, specifically EGFR and KRAS, that there are significant and substantial differences there. Looking at this pie chart here, so in the occurrence of these specific types of cancer, if I now take cohorts of Asian patients or German patients or even European patients, why is it actually the case that there are such significant and noticeable differences? And what exactly are the implications for us when so many of these studies are actually being conducted in China with exclusively Chinese patients? Does that really help us here as lung cancer patients in Europe?
So, to what extent can we truly compare these two things? It seems that we do not yet fully grasp all of this because, of course, there are some significant differences. Some of them smoke less, some smoke more. They are exposed to different environmental influences. Some live in cities with a lot of industry. Others live in completely different places. I really think that's already quite different from the way things are currently done in Europe. We don't know whether it's still comparable or not. We don't know whether the way such a tumor develops is really the same as it is for us. For example, 25% of patients in China with small cell lung carcinoma have never smoked. That is extremely, extremely rare in Germany. So you can see differences, and yet I still believe we can learn a lot because much of it is comparable. The medical standard in China is already very good in some places, depending on the location. But there are incredibly massive hospitals that are significantly more extensive than anything we have here in Europe. That should definitely be given very serious consideration. The fact that so much is now coming out of China shows that China is a huge country with a great deal of ambition. They are deeply committed and determined to develop their own medical products. And they are doing so with impressive skill while simply investing in their own location. Here, many of us are initially cautious and skeptical towards the pharmaceutical industry and often wonder, what exactly are they actually doing? That's actually quite a bit more distinct in China. I'm not saying that one particular perspective or attitude is justified and the other isn't, But at least the ambition to build up the industry has a somewhat different dynamic in China than it does what we typically see over here. And I think we can learn a great deal from the Chinese in that regard as well.
You're also addressing an important point that concerns us as patient representatives. So, how do I effectively explain to patients just how valuable and significant participation in these studies can be?
Yes, I definitely agree.
Or also for future patients for that matter, and that it's really exceptionally well regulated, that there's an ethics committee overseeing the process, and so on and so forth, so that you truly have no reason to be afraid you won't be abandoned, that something will be abused, that you'll sign something and then can't get out of it. It's really important for us to keep pushing this forward and to make it clear to patients that there's a big opportunity for many people in participating in such a study.
That's very important. And of course, there are countries in the world where patients have very few therapy options because their insurance simply doesn't pay for anything. For them, access to a clinical trial is essentially vital. This is often the only way they can receive an effective therapy at all. And accordingly, the data sometimes doesn't always match what we see because we have access to a huge pool. We're still a wealthy country and can draw from a variety of therapies. And yet all the medications we use were once developed in clinical trials. And of course, no company will invest in these extremely expensive phase 3 clinical trials unless there is real hope that it's better than what we already know. And every phase 3 study compares the potentially better option to the best treatment we currently have. So, as you already mentioned, it is always very strictly and carefully controlled. There are numerous important safety aspects involved in this process, and many of the patients we treat have already received in clinical studies what was only officially approved 5 or 6 years later. And as a result of this, they are often extremely happy and satisfied about that.
You also mentioned regarding this particular study that the management of various side effects presents a set of very significant challenges. Is there anything that can still be improved in specific clinical areas to better prepare the patients? Or what other options might be available
Yes, so you
for
really
them?
have to say this stomatitis, this inflammation of the oral mucosa can be quite nasty at times. And then you can consider whether mouth rinses, cortisone, or some kind of local medications can help prevent the condition to some degree. But how successful we will actually be with that is something that still remains to be seen. I think we will have to wait and observe the results, especially when more comprehensive data from Caucasian patients becomes available. I do not know for certain whether Chinese patients will report the same extent of symptoms as we do. I simply don't know that. This is not intended as a criticism, but rather we just have to ensure and make certain that our patients' quality of life is maintained at the highest possible level. That will still be possible with these medications, but I have to say the body can actually get used to a lot of things. Still, we'll have to see to what extent in some patients the treatment might not be able to continue or the dosage may need to be adjusted. We've already gained some experience with this here in Gauting, and we noticed that it does work. Sometimes it's more difficult, sometimes not quite as difficult. It really depends a lot on the individual person.
Okay, then let's move on to the next study. Now we're looking at the TRITON-Study, which is a multi-center phase 2 clinical trial. This one deals specifically with patients having metastatic non-small cell lung cancer without squamous cell carcinoma, who also harbor certain genetic mutations. Specifically, we are looking for the presence of STK11, KEAP1, and/or KRAS mutations, but notably without any EGFR or ALK alterations. Now, looking right here in the first-line setting, tremelimumab and durvalumab plus chemotherapy are being directly compared against pembrolizumab and chemotherapy, which represents what we call a dual immunotherapy approach.
Exactly. There are various studies. Both the chemotherapy with pembrolizumab and the chemotherapy with durvalumab and tremelimumab have each shown, in comparison to chemotherapy alone, that they are better. And there are detailed subgroup analyses regarding these mutations. And there have really been some excellent and insightful studies that emerged, come from the lab, which have shown that if these mutations are present, then immunotherapy may be less effective. So I need a dual immunotherapy that includes this tremelimumab If you look at the study subgroups now, you see that yes, the benefit may possibly be better for this combination of durvalumab and tremelimumab, but we've never had a direct comparison. People are particularly interested when combinations of these mutations are present, such as KRAS plus KEAP1 or KRAS plus STK, which is not very common. It's actually quite rare. And when I saw this TRITON study, I thought, oh, great, finally a study is being conducted that compares chemo with one checkpoint inhibitor versus chemo with two checkpoint inhibitors. Unfortunately, I have to say that this study was so extremely poorly received by patients that it couldn't really be carried out in a proper or effective manner. That's why it was downgraded from a phase 3 to a phase B study, and it also didn't include as many patients anymore, only 84, and those are not numbers that allow you to make any statistically significant or major statements. So, what exactly did they look at in this case? Well, progression-free survival, overall survival, and so on. You can already see that the combination with two checkpoint inhibitors actually seems to be a bit better in terms of the clinical response. You see these unusually irregular and jagged curves representing the duration of response. Maybe it's a little better, but as you can see here, a mere 15 and 16 individual patients were ultimately evaluated. And of course, that's simply a matter of one or the other. Now, this is not actually in the form of a combination of STK and KRAS or KEAP and KRAS, but those cases would have been exactly the interesting patients to study. So you could say, well, it may be that it works a little bit better overall. With these limited number of patients involved in the study, you can't really say for sure, and actually we're left with the same level of uncertainty as we had before. The number of patients simply wasn't sufficient to answer this question definitively. Even if you think, okay, this specific combination with a second agent does seem to be a bit better. That would somewhat reinforce the prevailing assumption that has been held up to now. But this assumption is not based on clear study data, but rather on analogies and comparisons between studies, which is always difficult. So when it comes down to it, we really have no idea at all.
Yeah, no idea. Exactly. So actually disappointing.
Yes, because recruitment was just too slow after all. We do already offer this to patients, so we suggest to patients with KRAS plus STK or KEAP1 to use this combination with two checkpoint inhibitors. Of course, the side effects are based on data from the lab and also from other studies, which I think, well, is actually quite convincing to me. I myself worked in the lab for 2.5 years. I find this information from the lab exceptionally helpful for our understanding. But of course, it is not an absolute requirement. And of course, it's not a mistake if you decide to only administer chemotherapy with pembrolizumab. It might be a little bit worse, but in general, it is often better tolerated than this double immunotherapy combination. You really have to look at it on a patient-by-patient basis. And this study confirms that no matter what you do.
And they pointed out that recruitment was exceptionally sluggish. You mentioned at the very beginning that it was not particularly well received by the patients. Are there any clues or indications as to why that was the case? Would it help, for example, to actively engage and involve patient networks to disseminate information and support recruitment for such studies? Or how do you see this situation?
So involving patient organizations is always a very good idea, because we are working together for the most effective therapy and the very best development possible. This study was conducted solely in America. One must not forget there are numerous other studies that are also interesting, especially regarding KRAS. With KRAS, there is a wide range of studies involving innovative medications, specifically designed for therapy patients. And as a patient, that would probably convince me more if I had KRAS rather than participating in a study like this. A few years ago, the study was extremely exciting in terms of its control arm and research question. Today, the world has moved on. Nowadays, we have more bispecific antibodies, antibody drug conjugates, and of course, targeted medications against KRAS.
Okay, all right. So then I actually think we don't need to spend too much time on this particular study and can just go ahead and move right along to the next one. This one is about the Delphi 304. This clinical study focuses on metastatic small cell lung cancer. Stable asymptomatic brain metastases were permitted for patient enrollment. and the study was designed to compare tarlatamab versus standard chemotherapy.
A very exciting substance. It was just approved a few days ago. It is not yet available in Germany except through special company programs. However, starting from mid-July, it is expected to be widely used in Germany as well. It attracted huge attention last year. Tarlatamab versus chemotherapy in pre-treated patients with metastatic small cell lung cancer. Up until now, there was only one chemotherapy, which hasn't changed in 30 years. And to be honest, it was always very variable, but most of the time it wasn't really a great therapy, neither in terms of effectiveness nor side effects. Tolerability, and now tarlatamab. Tarlatamab is also a specialized bispecific antibody with two distinct targets. On the one hand, it directly targets and attacks the tumor cells again, and on the other hand, it effectively stimulates and activates immune cells, leading to an entirely distinct and even stronger immune response than these checkpoint inhibitors. In some patients, it demonstrates such remarkable efficacy that it is significantly better than traditional chemotherapy. The data that was presented last year was truly impressive. The best data in the last 30 years regarding the advancement of therapy for small cell lung cancer. And this is becoming, and already is, the new standard for pre-treated small cell lung cancer in stage 4. And of course, we know that small cell lung cancers in particular often form brain metastases. In the study, asymptomatic brain metastases were allowed. And now this analysis of the study looked at how brain metastases actually fare under this palatema treatment. Does it also have an effect in the brain? That was the background. And of course, patients were not specifically screened or examined for brain metastases, but it was ensured that both arms had an equivalent and balanced number of patients with pre-existing brain metastases, which, however, had to be asymptomatic. They were certainly allowed to have received prior radiation, but in some cases, the metastases were still clearly visible on imaging. And what exactly did they look at? They looked directly in the brain with MRI. How do these brain metastases change under tarlatamab or under chemotherapy? How much time does it usually take until the tumors in the brain start to grow again? That's always a tough thing that you can't ever really predict. We don't know how well the therapies actually work in the brain because of the so-called blood-brain barrier. We know that chemotherapy also has an effect, but whether tarlatamab does anything, we don't know or didn't know until now. Because what we saw is that almost 40% of patients had brain metastases included in each of these two study arms. Most had previously undergone radiation therapy, which means it was assumed that things would be calm now. But you can clearly see that in a significantly larger number of patients, these tumors became smaller again, in some cases even vanishing entirely from the body, what we call complete remission, occurring 3 times more often than with chemotherapy. So chemotherapy also has a positive effect, but tarlatamab is simply substantially more effective. And the duration for which the disease in the brain was successfully managed and controlled was also much better with tarlatamab than with standard chemotherapy. And that is very important information for us, especially as we start to use tarlatamab more widely, which is not that easy to handle, particularly when it comes to the first 2 doses. Then the question always comes up, what about patients with brain metastases? Can we perhaps even wait with radiation therapy? And for me, the answer is yes, we can wait. We can observe for now, because we know that tarlatamab also has intracerebral efficacy. I don't want to advertise the drug too much here, but these are really impressive data.
I think that has absolutely nothing whatsoever to do with advertising. I think that's really incredibly encouraging and positive news, especially for this particular type of lung cancer. If such a highly effective medication has been rigorously tested and clinically proven,
there will also be competition. Every company or many companies are now developing drugs with a similar profile of action. But for now, this is the only one available.
Well, you mentioned that there is a significant tumor response, but we are also seeing a robust immune reaction in many of the patients. That means we see cases of high fever, cold chills, intense shivering, and a significant drop in blood pressure, but these side effects are all still quite manageable with medical care, I believe.
Yes, although manageable is a very flexible term. basically a doctor with more experience is always better than someone with less experience. And with these medications, you don't have a long reaction time because, of course, there can be mild cases where you just have a bit of chills or a slight fever. That's obviously not dramatic, but of course that there are also patients for whom it's completely different. And distinguishing what is serious and what is not, in my opinion, really comes down to experience. And I think especially the first 2 doses should be administered under supervision. The patient must be properly informed that even after being discharged, since the infusion only takes a few hours or actually just about an hour, and then we observe the patients sometimes even for 24 hours with monitors so as not to miss anything. But of course, this can still occur at home. Then it's important to know what the patient can do. But then administering it on an outpatient basis works wonderfully and is generally very well tolerated. Sometimes there are entirely new side effects, such as neurological symptoms, which are typically quite mild, but should certainly not be missed. However, these can generally be successfully managed under outpatient conditions, especially with the provision of proper patient education. So not completely trivial to do, I think so.
The neurological side effects that occur more frequently, is that due to the good intracerebral efficacy? Or what is the reason for that? What is
Good
the
question.
cause?
Personally, I would actually say no. So the effectiveness probably has nothing to do with that. It is more likely that the endothelial cells, that is, the cells that form the protective blood vessel barrier, are also affected to some extent, a little bit. The clinical effectiveness is probably more attributed to the fact that these brain metastases no longer have a good blood-brain barrier. And therefore, these antibodies can function quite effectively in the brain.
Good news? Good.
Absolutely, absolutely.
Well, then, right at this point, first of all, I want to say a big thank you to you, Professor Reinmuth, for the interesting insights into the research results of immunotherapies and the information on what each of these means for everyday clinical practice and for the patients. Thank you very much.